Awesome. Well, I think we'll go ahead and get started. We know some people are running a bit late, and Dr. Sharma is getting out of clinic right now, who's co-presenting, but we're gonna have Rachel go first anyway. So we'll go ahead and get started. And I think I know some of you, but also am meeting some of you all for the first time. So welcome to our roundtable series. This is our fifth roundtable in a series of about 7 to 8 roundtables, and we're going to be talking today about forced poverty and income inequality. And we've done a variety of different roundtables in the past, from peer support to medical trauma to healthcare transitions. And this series is really centered around the identifying some of the most pressing needs of young adults with chronic and rare conditions specifically, and also identifying opportunities for future research or systems change. And so I'm going to go ahead and share my screen and go through just a little bit about more about the roundtable, and then have Rachel take it away from there. So as I mentioned, this is our fifth roundtable. And oh, I forgot to introduce myself. I'm Seha. I'm the executive director at Generation Patient, and I have a variety of our team members here, as well as our community members who have informed the roundtable series, as well as the specific topics and discussions. So a little bit about Generation Patient. We do a variety of work in direct support, research and policy, and leadership programming. And then we do these roundtables to really bring together patients, providers, researchers, and other stakeholders to come together and identify solutions and next steps for some of the challenges that we identify. Acknowledgements, we really like to thank the Lucile Packard Foundation for Children's Health for supporting this series, and Allison and Rebecca are here today, who are our program officers, and we're super grateful for them for allowing us to do these series and to be able to publish based off of the findings of these roundtables. And thank you, Dr. Catherine Melton, who has been really instrumental in helping our community members have their voices and experiences shine in peer-reviewed publications. So after all of these roundtables, we have a proceedings that I'll talk a little bit about in a second, and then we always have a young adult patient as a first author, which is very important and exciting to changing the traditional paradigm of peer-reviewed publications. And thank you to Meg, who's here as well, for helping with coordination and identifying some of you all for this roundtable and for the subsequent ones. So broadly, our roundtable goals are to initially preliminarily publish a proceedings document that further identifies the system's challenges and opportunities for young adult patients. And the second is to continue multi-stakeholder collaboration to improve outcomes broadly for young adults with chronic conditions in a variety of different topic areas and sectors. And we're very excited to have had our first proceedings published a couple of weeks ago in healthcare transitions. And Caroline, who presented at this first roundtable, was our first author, and of course with the support of Catherine as well. So we encourage you all to check out that first published proceedings, and also know that for this roundtable, we will also be publishing a proceedings document. I will go into roundtable rules a little bit later in just agreements, but before we get into the discussion portion, so first Rachel will be presenting, then Dr. Sharma, and then we have a series of discussion questions to really get your thoughts and insights and expertise, because we know that you all come from a variety of different backgrounds and carry different set of experiences, which we'd really value to collect data and information on. So I will stop sharing my screen and turn it over to Rachel to present your video.
Hi, y'all. I'm Rachel. I pre-recorded this just because I have some difficulty speaking, so I'm going to just share my screen and then it should play from there. And you're all able to see this, right?
Yeah.
Okay, cool.
Hi y'all, so today I'm going to be sharing a bit about my own experiences with forced poverty and income volatility. First, just a bit about me. I know that some of you know me already, but for those who don't, I'm Rachel, my pronouns are she, her. I was a 2024 health policy scholar with Generation Patient, and I'm currently a freelance journalist and cartoonist, and I have been for several years. Before that, I worked in the youth homeless services sector for 4 years before I became too ill over the summer of 2024 to continue that work. And I have several chronic illnesses, including POTS, severe ME/CFS, and a still unspecified central nervous system / upper motor neuron disease, which is why I use a wheelchair full time. And then finally, this presentation is pre-recorded since I have some challenges speaking for extended periods, and because this presentation is occurring in the evening when I have a lot of challenges with fatigue. So my experiences with forced poverty and income volatility, for the most part, started when I was around 18 years old. Growing up, I had involvement with a number of different institutions and systems. It ultimately displaced me from home, led to fragmented community connections, and that extended trauma led me to become homeless when I turned 18. And at that point, I was living out of a youth shelter the summer before college. And while I'm super grateful for the support they provided, they did not really prepare me for knowing how to support myself on my own without any family, or apply for Medicaid or other kinds of benefits that would help me with a lot of the health issues that I was experiencing at that time. And so when I entered college, I had no idea about Medicaid. I had no idea how to get any of those kind of public benefits. And for the most part, for that entire freshman year of college, I didn't have any health insurance. I didn't have any access to health care, except for university health services, which, as you probably know, are not equipped to handle pretty much any kind of chronic illness. Thankfully, after that first year of college, someone told me about Medicaid and that I might be eligible. And so I applied for Medicaid. I was approved in June of 2018. And in July, I managed to get an appointment with a cardiologist at my local university hospital. And when I saw that doctor, I was diagnosed actually quite quickly with POTS, which is a circulatory / neurologic condition. And I was started on meds that would help me with my symptoms. I was so glad to have, access to health insurance at that point, access to care, access to medications. And I really thought when I entered my sophomore year of college that things would be better. However, that sophomore year of college, when I returned to school full time and submitted my updated financial aid to the state of Wisconsin, they saw that I had received a scholarship, and they counted that scholarship as income since some of it was coming to me to pay my living expenses. And ultimately, that scholarship that I received kicked me off of Medicaid, and I was once again without health insurance just a week into my sophomore year of college. And this process of just making a little bit of income and then being kicked off of public benefits is called a benefits cliff. And for reference, I live in Wisconsin, which is one of only 10 states without expanded Medicaid. So in 2018, this meant that making just a few dollars over $1,000 a month was enough to kick me off of my Medicaid and enough to make me no longer have access to health care. And because I no longer had any access to healthcare because of my insurance loss, my health declined. I had to leave my job. I had to drop out of pretty much every single class in school. And when I lost my job again, I was able to get back onto Medicaid again. And that process of cycling on and off Medicaid because of small, non-sustainable changes in income is called Medicaid churn. Soon after my sophomore year of college ended, the COVID-19 pandemic started. And while this was a really challenging time for a lot of people, a positive that came out of it was Medicaid continuous enrollment. And essentially what this means is that Medicaid beneficiaries could not be disenrolled from Medicaid for fluctuations in their income. So I was able to accept scholarships again, I was able to work more without fear of losing my benefits, and I was also able to save money. And continuous enrollment lasted all the way through the last year of college for me. And so that was a really great chance for me to get more stability. I was able to move into my own apartment with the money I'd saved. But unfortunately, right after that last year of college, continuous enrollment ended. And so I lost my Medicaid, and all of that stability that I had been able to build up for myself crumbled really fast. So what happened when I lost my Medicaid after my final year of college? Well, I ended up moving on to an Affordable Care Act plan through the health insurance marketplace. And that's where you can find plans that are subsidized by the government, but they are not Medicaid, and they often have really high deductibles and premiums, and they don't cover a lot of the things that Medicaid typically covers. And so on the marketplace, my only option for health insurance, if I wanted to continue to see the same doctors, was an Anthem Blue Cross Blue Shield plan. And let me tell you, trying to work with Anthem is like entering hell. They didn't want to cover my meds, and you can see on the right side an illustration where I cut out some words from a letter they sent me when they were trying to deny one of my medications, and it says, generic drugs work just as well and can save you money, which really just saves them money. So that was a fight, trying to get them to cover my essential medications. And then I also had to fight them trying to do physical therapy outpatient because they said I wasn't improving enough. And then finally, in July of 2024, when I had a sharp progression in my chronic illness and landed in the hospital for nearly a month, they didn't want to cover my stay in an inpatient rehabilitation facility because I was improving too much. And they said this even though I had lost my ability to walk and had become a full-time wheelchair user. And so it was just a completely hellish experience trying to work with Anthem. And unfortunately, the rehab hospital that I was in didn't really care that my insurance didn't really care that I couldn't walk, didn't care that I had an inaccessible apartment with 20 stairs. The moment my insurance said they weren't going to cover my stay anymore, they said, you got to get out of here. And they ended up discharging me from rehab to get into my inaccessible home. And to make matters worse, they not only discharged me from rehab to get into my inaccessible home as a full-time wheelchair user, they also discharged me the day I tested positive for COVID acquired in their facility. And so even though my initial plan had been to drag myself up the stairs with my arms, COVID made me too weak, and I was no longer able to do that. And so once again, I ended up homeless. And this time, thankfully, it was a transient experience. It was only for 3 weeks, but it was terrible. I had COVID. I was so weak. I was not able to walk, navigating these huge changes in my health and body. And then finally, when I was more recovered from COVID, I was able to drag myself up the stairs of my apartment. And I spent the next 6 months trapped in that apartment because I could not find affordable wheelchair accessible housing, and because I lost my job from being too sick to work, from being trapped in my apartment. And so at that point, once again, after losing my job, I was able to return to Medicaid, and I was approved for long-term care services, known as home and community-based services, which means that Medicaid pays for caregivers to come to my home and help me with basic activities of daily living, which for now keeps me out of a nursing home and keeps me in a more stable position, even though I'm still not able to work enough to not live in income restricted housing, which is where I currently live. And now, as you are all probably very much aware, the current administration is trying to dismantle Medicaid, which includes things like home and community-based services, which I rely on. And they're also proposing Medicaid cuts, and more specifically, work requirements, which would likely kick anyone like me off Medicaid who's not able to work. And that also includes many, many other disabled people who are also not able to work enough to meet those requirements. And unfortunately, because Medicaid and access to healthcare in this country is still not considered a basic human right, the cycle of precarity and financial instability will always continue to exist for disabled and chronically ill people, so long as healthcare remains for profit. Then finally, to wrap things up, I know I talked a lot in this presentation about broad systemic issues, things like Medicaid, housing instability, the ACA, lack of insurance, but it's not just financial precarity that worsens health outcomes, it's also how healthcare providers respond to it. And again, while this is a whole other topic and I'm not going to get too much into it in this last slide, things like discrimination, suspicion, stigma, bias, blame, these are all things that impact people experiencing homelessness and precarity, especially if you have other marginalized identities. And so, to conclude on a somewhat more hopeful note, the way that healthcare providers respond to patients experiencing these things is perhaps easier to change than our massive for-profit healthcare system. For example, what if rehab had fought to keep me in the hospital when I got COVID rather than boot me out because my insurance lapsed? What if they had shared their financial assistance policy? Obviously, these are things that take advocacy, but I see these as areas where clinicians and case managers can step up and potentially prevent patients from experiencing some of the same things that
Thank you so much, Rachel, for sharing that presentation with us, and would love for you all to react to it in the discussion portion as well. So feel free to keep your all's thoughts and reactions in the chat, of course, but also during the discussion portion. I'm going to hand it over to Dr. Sharma now to present from the provider perspective, and then we will go into all-around group discussion with some prompts. So Dr. Sharma, would you like to share your screen?
Absolutely. And let me just, first of all, just start off by, Rachel, that was an amazing presentation, and you're a very, very hard act to follow, to be honest. I think we were initially planning on me going first because really all of you are here to hear Rachel and not hear me. But I think what I will do is kind of sort of look at the topics that Rachel discussed more at a 30,000-foot level. And as I talk, maybe let's remember everything that Rachel talked about, because I think it's absolutely relevant. I want to also very much apologize for being late. My clinic ran late this evening. But the reason why it ran late, I think, is very, very relevant to this discussion, because my last patient was a 21-year-old gentleman with, I'll just say, a genetic condition, a genetic syndrome rather. And I was on having a virtual visit with him and his mother to help him find an adult primary care physician in our network. And part of the I'll use the word crisis, is that a lot of his services are actually ending when he's 21 right now. They end on his birthday when he turns 22. So we have a bit of a deadline to help him find a primary care physician, but also to um, ensure that he gets his ongoing services. So I apologize, but for a relevant reason. And Sneha, because I literally parked my car and ran upstairs, I need a moment to just pull up my slides. So if you can just give me a sec, I'm hoping that I'm just going to look for the one that I emailed you because it'll take me more than a minute to log on to my system remotely. So if you just bear with me a sec. Um, let's see. Awesome. I just found it. Perfect. Okay, great. And then let me do this. Okay, great. So I'm hoping that everyone is seeing my screen now. Is that correct?
Yes.
Okay. Now the bad news is that because I'm in a rush, it's I have two screens, and the screen that I'm looking at is above me. So if I'm looking up, it's not that I'm not paying attention or sort of rolling my eyes, it's because the screen is up there. So I'm sorry about that. So what I was going to do is really focus on kind of U.S. health insurance and once again, is everyone seeing my screens?
Yes.
Okay, thank you. What I'm going to do is focus on U.S. health insurance and sort of threats to coverage, very much relevant to the discussion that we had. I have nothing to disclose. So I thought what I'd talk about is the health policy problem, a little bit about health reform that Rachel talked about, and then Meg gave me the idea of just talking about where to go from here, which will, I think, tee up the discussion that we're about to have. I meant to say at the very beginning, I'm a huge, huge, huge fan of Generation Patient. I've known about the work that Sneha and the leadership have done for years, and you all are amazing. So to have an opportunity to be invited here is an honor for me. All right. So I think a lot of what I'm going to say, and I'm going to try to just go through my slides really fast because I think the discussion is going to be much more interesting. There's a paper that myself and Lauren Wist from the UCLA wrote that sort of updates the number of people with chronic conditions who turn 18 every year. The number that's sort of floated around is 500,000. It's actually about more like 1.2 million people turn 18 every year, just to give an idea of the scope of the problem. Now, the challenge is that, and a lot of what I'm going to tee up is sort of pre-ACA, is that 30% of people between the ages of 18 and 24 lack a payment source of payment for needed health care. And the challenge, of course, is that healthcare in the United States is really tied to work. And this is kind of what Rachel is alluding to or sort of talking about. But because people have chronic, have fewer sort of work opportunities to work, many are fearful of losing their Medicaid eligibility. Is exactly what Rachel is talking about. And then young adults with special health care needs are 3 times more likely to live on low income. About 40% of college graduates don't have health insurance, and 50% of high school graduates who don't go into college don't have health insurance. Um, as I'm kind of getting at, and as Rachel discussed, if you don't have a job, it's hard to get on private insurance. And then Rachel talked about how that sort of income gap, if you make too much, you can't get on Medicaid. If you make too little, you can. And there are challenges related to that. We know that and this is older data, but it sort of drives home the point that young adults, in particular people in the 18 to 24 age group, which is kind of what we're talking about 35% don't have health insurance, and so that's a huge problem. And I'll just say that two out of 5%. I'm going to kind of fly through this, but the point here really is that 2 in 5 2 out of 5 young adults spent some time uninsured over the past year, and it's really even higher for people who are as you kind of go up in their level related to poverty. And so there are lots of insurance gaps or sort of underinsurance. As Rachel talked about, there are lots of things that people need to access, like habilitative services, like physical, occupational, speech and language pathology, medications, durable medical equipment, hearing aids, things like diapers, and mental health services, dental care. There are lots of things where there are gaps in the insurance. And so this leads us to healthcare reform. So we remember, and I vividly remember the efforts that took to pass the Patient Protection and Affordable Care Act. And there were some amazing things that came out of it that the law sort of talked about. So that it prohibits private insurance companies from denying coverage to children under the age of 19 based on a pre-existing condition. That idea of guaranteed renewal prohibits rescission of coverage, sort of gets away from the idea of annual caps as well as lifetime benefits, extending people on that they can stay on their parents until the age of 26, continuity care for people in foster home. And you can kind of read the other things there. And of course, then there are these essential benefits. That's the opposite of what I just described. So access to ambulatory care, emergency services, hospitalization, laboratory services, pediatric services, preventive and wellness visits. So those preventive annual exams should not have a deductible associated with them. Rehab and habilitative services, prescription drugs, and so on. Now, this made a big difference. So this is I'm guessing, a very difficult slide for all of you to read, but essentially what it does is it talks about the sort of impact that the ACA had on coverage and access to Americans with chronic conditions under the ACA. This is divided by race. So each of these dyads is white, black, and Hispanic. And you can see that non-expansion states versus expansion states. And you can just see, just eyeballing it, that it went up for each of each racial group, but that there's a difference between whites and, let's say, Hispanic groups, that there's a more substantial, so there's a disparity that exists despite the ACA. This also goes along with people's ability to afford a visit. So once again, the dyads of expansion versus non-expansion, white, black, Hispanic, and you can see that whites is people who identify people are whites are higher as compared to, say, Hispanics. And then this is looking at their ability to find a personal physician, higher for whites compared to Hispanics, but there's been an increase for expansion versus non-expansion states. So has been an increase in people being able to say they identify personal physician, but there are still disparities. And then this is receiving annual checkup. I'm just going to breeze through this one. Now, one of the things that I think is pretty notable is sort of still looking at the number of uninsured people based on age. So now this is from 2013, but I think it drives home the point that up until the age of 18, yes, there are people who are uninsured. So let's say a 17-year-old is about 10% or so. And then people over the age of 65 who qualify for Medicare, it plummets. So 65-year-old is sort of below 5%. But look what happens when someone turns 18. So this is despite the expansion of health insurance, ability to receive health insurance. There's still about 25% of people kind of in the young adult age group who don't have health insurance. Now, this is a paper that Lauren Wisky and I wrote looking at sort of the probability of having full year insurance amongst people who are between the ages of 19 and 25. Without getting into the sort of the statistics of it, I think the reason why we did this paper is to, first of all, see if there's an improvement. And second of all, to look at what the disparities are, what disparities exist. So you can see that sort of pre-reform, that's the blue, and red is the post-reform, the percentage of people who say that they had a full year of insurance, overall, it increased. So it went up by about 10.7% for overall. But then if you look at it by race, that you can once again see disparities. So for white non-Hispanic, it went up substantially, up to close to 75%. For Black non-Hispanic, it went up, but it went up to below 70%. For Mexican Americans, below 65%, and for Hispanic white, sort of like in the 67% range. So it went up for all groups, but it went up less based on people's race. Now, the next thing we looked at were sort of citizenship in language. So overall, once again, it went up. If you're born in the US, it went up to about close to 80%. But if you're non-citizen, about 6%. If you speak English, about 75%. And if you speak any other language, about 63%. So once again, you're seeing disparities there. And then the final thing, oops, sorry. And then the final thing is sort of where is income. So overall, once again, it went up by about 10%, 7% overall. But if you're in the 50 to 99% of federal poverty level, went up to about 57%. And you can see if you're at 500% of the federal poverty level, close to 90%. So once again, even with income difference, there are disparities amongst income differences. Now, the final thing I was going to bring up here is sort of, is insurance enough? And I think this is sort of an important point to raise, that just having insurance isn't just the whole story. So I think as and to bring home my point, I'm going to compare Massachusetts, where I live, and I forgot to mention, or I think you saw my title slide, practice in Boston. In Massachusetts, we have about a 4% uninsured rate. That's because we had the ACA before there was the ACA. In fact, the ACA is sort of based on expansion here in the state of Massachusetts. Comparing ourselves to Texas, that has an uninsured rate of approximately 20%. Now, what I'm going to do is compare whether people have received certain services to allow them to transition from pediatric to adult care. So just kind of run with me on this one. All we're comparing is people who have a medical home or not, and whether they receive the transition services they deserve. What I want you to look at, can you see my pointer or no?
No.
No. Okay. So let's just look at the bar on the far right-hand side. What I want you to just remember is that the red bar, orange bar, that people who did not have a medical home, 71% of them did not achieve this transition index. Okay, are you with me on that? Let's just remember that number. So this is nationwide versus Massachusetts. So people with a medical home and without a medical home, let's look at the I'm sorry, the colors changed, and I'm sorry, I apologize for that. So as outcome not achieved is orange. So what I would say is that people without a medical home, it's on the far right, it's about 28% achieved this outcome. Compare that to Texas, where on the far right is 22%. So even though Massachusetts has a lower uninsured rate, we're not that much different than Texas. So there's a lot more to just having insurance. And I think Rachel's point kind of drove that home. I'm going to skip over this just to say that there are inequities based on race as well. So where do we go from here? And I think that Rachel teed me up absolutely perfectly. And this is really just to start a conversation. So there's a threat that Rachel absolutely talked about, that if, and we've heard about this tax stuff that's going on, and that's the reason why we have a government shutdown right now. So this is just an example of how premium payments will increase in 2026 if the ACA enhanced premium tax credits expire, which is what this whole debate's about. So it's in 2025 is roughly $888. It's going to more than double to about $1,900 if this tax credit goes away. You can imagine what's going to happen to people who require the ACA to buy their health insurance. They're not going to buy it. And in order for the healthcare marketplace to work, we need everybody to kind of pay in. That's how insurance works. And so that's why premiums are going to go up. The number of uninsured is going to increase as well. So my final slide is this, that the data is there. And I think what is required is advocacy. Stories like the one that Rachel just told are critical for policymakers to hear. I'm going to just say it that Massachusetts less so. I think our congressional representatives are all united in sort of what needs to be done. But if people live in states where there was an expansion or where they have a congressperson, it really is incumbent upon all of us to share our personal stories and our experiences. So for people like Rachel, and I'm sorry, Rachel, I keep referring to you, but you gave such a powerful presentation. For all of us to share our experiences, not only what we currently are facing, but what we would face next if this doesn't happen. I go back to the 21-year-old who I saw literally finished seeing him at 6 p.m. Eastern time, so about an hour and a half ago or so. I mean, he's in trouble. Like it'll be a big problem for him when he turns 22. With that, that's my email address if people want to reach me. And just thank you very much. It's just such an honor to be here and to be invited to speak at something that Generation Patient organized. You all are incredible. So thank you.
Thank you so much, Dr. Sharma. And